Okay, awesome. Thanks for having me, and thanks, Katrina, for the great kickoff for the presentation. So, maybe changing gears a little bit, but talking also about my experience and specifically something I'm very passionate about, which is this idea of improving how we do health promotion in the medical space and across treating from illness to really empowering wellness. So I want to start off with a little bit about myself as well. I think too often we kind of define ourselves by our research and our title, but I think connection fuels collaboration. So just to tell you a little bit about myself, I'm German Canadian. I moved to Canada when I was pretty young, but most of my family is still back there. I'm an outdoor enthusiast. So when I tell people I moved to Calgary for a PhD, the real truth is that it wasn't primarily for the PhD. It was primarily for the Rocky Mountains. And I've lived in quite a few different places, so fortunate to gain those experiences of living in Germany, Canada, Sweden, and Tanzania as part of my past. And my retirement plan, as a fun fact, is to open a pizzeria or bakery. So we'll see how long that takes. And then a little bit about our work. So our work kind of sits at the intersection of these three different areas. So health behavior change, my background is in physical activity behavior change. Implementation science is what I've really focused on over the past years in my postdoc. And then really the use of digital and other interventions to both prevent chronic conditions and maintain good health, and then improve function and well-being for people who already have chronic conditions. So with that, well, I'll be talking a little bit about why movement matters and why money talks. Share some small wins from our work, and then share some reflections. How do we move from winning games to changing the rules? So with that, I want you to kind of put yourself into maybe a little bit of an abstract scenario. Imagine you hire a financial advisor, and this is kind of the investment profile that you get. So you have two different stocks, stock A and B, and one has a 27 to 1 return on investment, one has a 1 to 1 return on investment, and then you see your advisor has put only 3% of your stock into stock B and 97% into stock A. So I want you to just imagine, would you be happy about that? How would you feel about this kind of investment plan? And I'll make it relevant in just a little bit here. So let's talk a little bit about movement. Again, with health promotion, there's a lot of different pieces to it, but movement is the one that I'm the most familiar with. So I'm going to be talking about it from that angle. It's definitely not the only one. And again, want you to ask a quick question. So how much weekly physical activity do you think is required to provide significant health benefits? If you want to throw some numbers in the chat, I'll try to pull it up here and be multitasking. I'll give it just a couple seconds to see if anyone has any ideas. 20 minutes, okay. 90 minutes, 30 minutes, 150 minutes per week. I see someone quoted the physical activity guidelines. 150 minutes a week. Someone said anything more than you've been doing. Amazing. Okay, so we got some different answers here, and I think this kind of highlights one of the difficulties in this is what is that number really? We saw the Canadian Physical Activity Guidelines, and while that's a good number to keep in mind, the truth is that any physical activity is better than none, and we actually see this really strongly represented in the data. So there's this really strong dose response between physical activity and the risk of chronic conditions and mortality. So this is a big review and showing kind of across a bunch of different conditions. You actually get benefit pretty much immediately from going from inactive to slightly active. So this could be anything from 5, 10, 15, 20 minutes. And the greatest benefit is actually in that initial piece. You see the slope of the curve is stronger there. So it's not just 150 minutes, it's any minutes. But yeah, with that, movement matters, but ultimately money talks, especially in the health system. And so another quick question here, quiz time number 2. What do you think the cost is of physical inactivity in Canada? Throw a number out there. Let's see. So much, huge, 1 billion, billions. The whole PIB of Canada. Okay. Amazing. Yeah, I think you guys kind of get the gist, but the cost is pretty huge. I'll put some numbers up here. But first and foremost, we had a recent physical activity report card from Participation last year that summarized kind of numbers from a bunch of different studies and surveys and those things. So we know 54% of Canadian adults are not insufficiently active according to those guidelines. and inactivity costs Canada 3.9 billion per year. And that's in avoidable healthcare costs alone. So this doesn't capture kind of employment absences, all kinds of different other things around that. If we just increase physical activity by a relative number of 15%, we could be saving a billion or more in costs. So this is really important. And in terms of return on investment, we're getting back to that financial advisor scenario. National health promotion efforts in a big review have been shown to provide a return on investment of 27 to 1. So pretty good return on investment. Maybe we should be investing a little bit more in that. And I think people have agreed on this for quite a while, but we haven't seen as much change maybe as we'd like. So this is a really awesome quote that says if exercise could be packaged in a pill, it would be the single most widely prescribed and beneficial medicine in a nation. Unfortunately, or fortunately for myself, to have a job that isn't quite this easy. So how do we actually improve health behaviors such as physical activity? Well, there's behavior change interventions. So these are on an individual level. We know these work. This is a review of over 2,000 participants in 16 studies. These interventions were able to increase physical activity by roughly translated to around 1,500 steps per day. And these changes were maintained long term to about the amount of 1,000 steps per day. So these are meaningful increases. We saw that curve dose response. These are huge in terms of a population level. This is one of the interventions that has been shown to work quite well. This is a very simple intervention called screening, brief intervention, and referral. Basically, it happens at the point of care or where there's interaction with a healthcare professional. And it's basically asking these three questions. What are you doing to stay physically active? So that's your screening. Brief intervention, let's talk about ways to move more, and having a brief conversation about this can be as little as a couple minutes. And then here's some resources to help you, or here's a referral to prescription to get active, or these kind of resources out there. So this works, especially when it's integrated well into clinics. So this is to show that this intervention, both for physical activity and other health behaviors, smoking and alcohol has a significant increase in or improvement in those behaviors. And then it's also cost effectiveness. So when we look at a review done in the UK for a motivational interviewing based approach, it was costed at $54 per quality adjusted life year. And this is well below the threshold that the UK has put, which is around 20,000 per quality adjusted life year. So this works, but why isn't it happening? Well, change is hard. Mind the gap in terms of physical activity habits. Less than 50% of people are physically active to those guideline levels. Health promotion by providers doesn't happen very often. There's a bunch of numbers out there, but one study showed that less than 30% of health providers are promoting physical activity. And in terms of investment, this is back to your financial advisor. Less than 5% of healthcare costs across OECD countries are going towards prevention compared to curative. So this is a big gap that we're trying to tackle. And when we work with individuals, we're really leveraging behavioral science. And when we work with systems, we're really leveraging implementation science and bridging those two. So let's talk about some examples, some small wins of can we move the needle? This is some of the work I've been doing over the last 2 to 3 years. So the first project is called Just One Move. This was a project focused on co-developing a physical activity toolkit for rheumatology. So the purpose was both to promote physical activity with individuals and also to help providers do this more effectively with their patients in terms of health promotion. So we co-developed some toolkits. First, we kind of tried to see what's out there. We did an environmental scan and an umbrella review. We then talked to patients and providers to do some priority setting. What are kind of the most important challenges you're facing? How can we address these with behavioral implementation science? And then we, dug in and co-developed some practical tools. We got some feedback, and next steps are kind of to implement and evaluate. Importantly, along all of this, we had 15 people with rheumatoid arthritis, and here's some of the awesome pictures of them, and 15 rheumatology providers involved. So this is what we got to. Encourage you to check it out kind of afterwards. It's called justonemove.ca. This is our website. It's live. It's been getting lots of growth and exciting attention. So we're working on next steps for that. And this is just to show some of the growth, and this has been pretty much without any marketing or major efforts, but we've got 140,000 search impressions, 12,000 site visits, and nearly 400 email subscribers. So it's something that clearly is getting some interest out there. And then these are some of the toolkits we've created for clinics. So we're working to implement these, but things like posters on what you can do in the waiting room, some action planning tools for providers to work through with patients. So that's the first project. Again, early stages, but we're starting to move the needle, I think, I hope. And then for the second one, this is really focused on cancer prevention. So this idea of physical activity, but other health behaviors in the space of cancer prevention. So this is more with my health system partner, Primary Care Alberta. We know that 50% of cancer deaths worldwide are attributed to modifiable risk factors, and these include smoking, alcohol intake, and physical inactivity as three of the key ones. So that's what we hope to target. And again, we use this intervention, screening, brief intervention, and referral. We aim to implement this into diverse clinical settings, as well as the electronic medical record in Alberta. We co-designed, we did some implementation training. This was before my time. Important to note is there are a lot of things to do in 2 years, and a lot of it was done before. Then we worked to implement and provide continuous feedback and support and do a re-aim-based mixed methods evaluation. So interestingly, we have some learning health systems experts here in the room, but we did leverage learning health system action framework to actually develop and leverage those gears before, during, and after implementation. I'm happy to chat more detail about this, but I'll move on in the interest of time. We then used the step wedge design. So any clinic that participated was first in that routine care arm and then randomly assigned to, at some point in our implementation, receive the intervention. So what did we learn from this study? It was a huge study. Again, lots of people involved, lots of resources. So that's the kind of the unspoken side of it. This was over 3 years, 11 clinical sites, and we had over 10,000 participants screened, and 2,400 of those consented to follow up. So did we see any behavior change? Well, yes, we did. Briefly speaking, this is across tobacco, alcohol, physical activity. This is all self-report, so caveat. But both in the control, which was screening only, we saw improvements in health behavior. So that's interesting to note that screening alone can actually make a difference. And this is reflected in previous literature. And then when we looked at the intervention, especially for physical activity, we saw a big increase. So this kind of seems to indicate to me that, especially for something that's more complex like physical activity, that brief intervention, that referral, that connection is so important to see change in behavior. So yeah, where do we go from here? I think we've been winning some games, but how do we change the rules? So let's talk about that. We've done some interesting work, but I don't think it's quite enough to just start and do all these interventions and small projects. We need a little bit of a culture shift to really invoke change. So one of the things we're still doing is we're really over-relying on busy clinicians. We need to de-implement and make some efficiency improvements to make space for health promotion in the healthcare system. We need to continue to empower patients. So this is not to take away that power from patients while we're working on slower systems change. And actually, one of the things we can do is improve clinician physical activity levels, because it's been proven that the more physical activity people are doing themselves, the more likely they are to support others. We also really need systems change and culture shift. So that whole idea of the investment in preventive health promotion type parts of medicine, there's a lack of top-down leadership and policy support. And we really need systems and culture that reward long-term vision rather than short-term wins. And I think Katrina really reflected this well with her kind of government change, and everything changes and then what happens? So a lot of progress gets erased. So things that I think are really interesting that are happening is things like policy work and system science, including this idea of physical activity as a vital sign. So integrating this into all medical visits as screening, and the idea of integrating exercise professionals and care teams. So I was actually really excited to see that one of the teams out in Nova Scotia for the new fellowship round is working on exactly this topic. And physicians actually have requested this for many years. There's an article there that from the Journal of Family Physicians in 2018 that says exercise specialists should be members of our care team. So they want it, we know it works. So let's move towards that. Again, I'll leave you with this. Every $1 of prevention saves $27 in healthcare costs. I'll leave you with two kind of funny notes, both about individual behavior change and about the challenge of doing preventative medicine in a medical space that is still driven by some financial interests. And then I'll invite questions and say thanks for having me.